Professor Kenneth Boffard. He's often known as the father of modern trauma surgery, and he'll be speaking to us on the treatment of bleeding. Is it to stop the bleeding, and are we making our patients bleed more? Prof. Boffard hails from Johannesburg in South Africa. He's a trauma director and academic head at Mill Park Hospital Academic Trauma Center. He's also the Secretary General and past president of the International Society of Surgery and a past president of the International Association for Trauma Surgery and Intensive Care. He's a military doctor as well, serves as a colonel in the South African Military Health Service. He's got extensive interests, and he is one of the pioneers in modern trauma surgery, and I would expect this to be an extremely engaging and interesting talk. Prof. Boffard, the floor's all yours.
Right, thank you very much. It's an honor to be associated with you here. The number of participants is a reflection of the organization, the people concerned, and it is really a pleasure both to be with my fellow speakers, but also to, as I'm seeing it, nearly 500 participants in this webinar. So my congratulations to all of you. Some of my colleagues will know that one can be very dogmatic. However, the reality is ATLS and equivalents have made a huge difference in South Africa and the world. We're to some extent on top of airway, but we're not quite as much on top of bleeding. The treatment of bleeding is to stop the bleeding. And by stopping the bleeding, you're probably going to save more lives than any other significant intervention. So the first comment to make is that stopping the bleeding is not a one-person exercise. It's a reality for more than one person. The pilot of the aircraft didn't expect the giraffe on the runway. I have no doubt that the runway was not, or the giraffe was not expecting the pilot on the thing. There was no losers. So the reality is resuscitation is a group effort. And if you don't have someone commanding the group, there is going to be a free-for-all. Unfortunately, that parachutist is about to discover this. So we can kill people by resuscitation as well as curing them. We can kill people if we don't have a single story that we are using. We are all, as they would say, singing from the same hymn book. And at the same time, the goals have got to be quite clear. The reality is, what are we trying to do? Resuscitation requires all your best efforts to achieve taking the oxygen in the air, concentrating it, transporting it from outside to the alveoli, it's called breathing, and then from the alveoli to the cells. That's actually called circulation. And then delivery from the cell itself to the target audience. That's straightforward. If, for whatever reason, the oxygen is not delivered, the body goes into its anaerobic cycle and you get lactic acid. So lactic acid is now part of what we would call the gold standard of goal-directed resuscitation. If you go for a big run and you end up with sore legs, that is lactate. Just to remind you, this is taking us back to our physiology, the dissociation of oxygen from hemoglobin is dependent on a number of things. The most important of all is hypothermia. If you become hypothermic, your ability to release oxygen from the hemoglobin is halved. So the end result is that if you, on top of it, hyperventilate that patient by introducing an endotracheal tube and squeezing on the ambubag and make them alkalemic because you have washed out their CO2, you then make them cold. The end result is that the oxygen stays on the red cells. It doesn't move forward. And that is so-called shifting to the left on the oxygen dissociation curve. So we have to have a warm patient with optimal ventilation. So the ABs still take priority, but the C is not far behind. Controlling the bleeding and maintaining the blood volume. Now that's not necessarily cell volume, but blood volume to deliver oxygen is the primary concern. So we've got to do two things, and we'll cover both of those. Every management process has risks and benefits, and you've got to do the right things for the right patient at the right time. That is the reality. So we start off by saying, what can we do with local agents? And there's a whole host of them. If you're in the military, you even more choices, from fibrin sealants to chitosan, which is made from prawns, to quick clot, to Surgicel, to gel foam, all trade names, all competing. The military tend to use a combination of either quick clot or Hemcon. Hemcon is quite expensive. It is made from prawn shells, and quality control is quite difficult. The one that is commonly used is quick clot, which is exothermic when it comes into the contact with moisture. You can get it to silly extents. I was interested at one stage. I went into an operating room in Johannesburg, and a close colleague was dealing with a really bad liver using quick clot powder. And I thought the operating room was on fire. And when I got in, I was convinced that it was, because there was a large cloud of smoke coming out of the patient's abdomen. It is very exothermic. It stopped the bleeding quite effectively, but has, of course, other complications. Nowadays, it comes in bags or impregnated bandages, and it's used pre-hospital to do two things. One, if you have a cavity, you can pack that cavity and stop the bleeding that way. The other is it is exothermic. The temperature of contact with the tissue will go up to about 60 degrees centigrade, and that will cause stopping of bleeding. It's not that effective on arterial bleeding, obviously. And then there are a number of others where the solutions can be mixed together, and you can inject that. It's quite useful for a stab wound of the liver, which is bleeding, and so on. So these are the local ones. Most of you are pretty familiar with them. What is factor 14? Nobody teaches us about factor 14 in medical school. What on earth is it? And the answer is it's the surgeon, or rather the surgeon's finger. I would suggest that if you have a large vessel, occlusion of that vessel by closing it with your finger or pressing hard on the bleeding is going to make a bigger difference than the other 13 factors put together. Never forget, the treatment of bleeding is to stop the bleeding. And there's lots of things that you can do that to try and get regional control. On the top of your picture, you see two military tourniquets. One of the important things on these tourniquets, and particularly the common one, which is in the center of your picture, is that white tag that you see on the top right. Here is a patient who has got major injuries to his lower limbs, and you could see that there are tourniquets at the top of that left leg, and that has stopped the bleeding. The bandages are not contaminated at all. But I do draw your attention to the picture at the lower part of the screen. The problem is quite simply the tourniquet is on below the knee. The end result is that leg is ischemic, and had that tourniquet on for nearly 6 hours, the patient, despite a wound that could have been controlled locally, lost his leg. And the white tag that you see on the top is for writing the time that the patient had the tourniquet applied. So where do we go from here? The patient is in the right of your picture. The trauma team is headed in to help. And not only that, but they've got a new armament weapon. It's called R.E.B.O.A. What is R.E.B.O.A? R.E.B.O.A is an acronym for resuscitative endovascular balloon. And it is inserted from the groin up the artery into one of three zones. One into the aorta itself, so-called zone 1. One around and across the renals, which is zone 2. And one just above the bifurcation of the aorta, which is zone 3. Now, that's well and good, because obviously you can blow it up and occlude circulation. And it looks like a glorified Foley's catheter. The problem is, where do you put it? Pre-hospital is not ideal because you're not sure where your positioning is, and you've got to be quite skilled at doing it. The Royal London Hospital does it. The results are still out for discussion. The emergency department, fine, and the operating room, fine. And then what's next? which condition. The one thing you should not do is put it in for blunt higher injury. So for example, if you've got a ruptured liver, the liver is bleeding primarily from venous wounds. And if you put in the REBOA, blow it up in the aorta, yes, it will stop arterial supply, but it also causes a rise in the venous pressure, which backs up, and the liver bleeds at about twice the rate. So blunt injury above the level of the pelvis, REBOA is probably contraindicated. Where you have got blunt injury below the pelvis and it's going to reduce arterial bleeding into the pelvis, there may be some indication. But we have a joke that if you have sometimes the situation we see dogs chasing cars, has anybody trained either the dog or the car what to do if the dog actually catches the car? And it's still a situation with REBOA. It's expensive. It's used in some major centers. It clearly has a place. There is a military place for it, but the place is still being defined. So REBOA, use it with care. There's a downside as well as an upside. Other regional control, most of you are familiar with. The bottom right shows bleeding of a liver, and that can be controlled with gel or stents or coils, that sort of thing. And certainly, I think nowadays in 2021, a ruptured thoracic aorta would probably be treated with the stent. Downsides to that too, because most tears are right next to the subclavian, and a stent put in by somebody who's not skilled may close off the subclavian. It may be necessary to do other things. After direct bleeding, however, coagulopathy is the commonest cause of bleeding-related mortality. And it's caused by a number of things. Firstly, dilution, we know, makes you coagulopathic. Secondly, we know that when you add certain individual items like saline, or for other reasons, colloids other than plasma, you end up with the same situation. So firstly, we dilute our patients. Secondly, we run in cold fluids. And thirdly, we run in the wrong fluids. End result, they don't clot. End result, they bleed more. End result, you have to give them other fluids, including blood, but blood also doesn't carry very much in the way of working platelets after a short while. So the treatment of bleeding is to stop the bleeding. On top of which, there's a relationship between the number of units of transfused blood given and the incidence of both multiple organ failure and sepsis. It's linear as far as the transfused blood is concerned. It's related to cell debris. Your first prize is probably fresh blood. There's very little cell debris. But certainly by within a week, you're ending up with a significant amount of debris, which clogs up lungs. And then the end result of that is that you end up with respiratory distress. The problem gets more complex with sepsis. The work is very clear. 2 units of blood will reduce your immune response. 4 units of blood will reduce your immune response by up to 16 times. The curve is exponential. So the more you transfuse, the more sepsis there is likely to happen later. The treatment of bleeding is to avoid the transfusion by stopping the bleeding. If we look at just the standard figures of the injury severity scores, that's the anatomy of injury and mortality, the more unit of blood that is administered, the greater the loss. Therefore, blood loss should never be entered upon lightly, unadvisedly, or wantonly. Absolutely not more often than absolutely necessary. The treatment of bleeding is not to give blood. Question: In 2021, if you went to America and asked for a license for a substance which causes cross reactions, transfusion reactions, carries 23 diseases, including malaria, HIV, and a host of others, cytomegalovirus, would FDA license it? So this is what we're trying to do. Optimizing the conditions to minimize the blood requirement. And one of the things that you need to look at yourselves, I hope in 2021, you have room in your hospital for a massive hemorrhage protocol. What do we do? How do you define a massive hemorrhage protocol? Most units would say 6 units or whole blood volume loss, but I would suggest that a massive hemorrhage protocol is needed if you lose more than enough blood to need 2 units of blood transfusion. You know, most times if you've got a hemoglobin of however you express it, 15 grams per deciliter, 150 grams per liter, most times the first amount of blood, you're not actually going to need a blood transfusion. Once you have lost 2 units of blood, you probably lost 6 units of blood overall. If you have lost 6 units of blood overall, you are into massive transfusion territory. So the massive hemorrhage protocol says, when you start transfusing, what and how, and I'm not going to go into the specific science, it's familiar to most people. And most people in 2021 will be revolving around something like, if available, a combination of red blood cells, platelets, and plasma. Blood in most countries, other than the first world, is very short supply. So one of the things that we audit very closely, and I've put up on the screen, is our blood consumption, because the first prize is you never waste a unit of blood. So the graph at the top of the screen is the unit of blood ordered over the last year. Next down in line is the unit of platelets ordered, and then the units of plasma given overall, and the bottom red line is the units wasted. This was a particularly bad month, in fact, because as you can see, we lost 4 units out of 74 transfused. Normally, we're running in the region of between 1 to 2 or 0 units wasted. We have an arrangement with the blood bank that all of the blood ordered comes up in picnic boxes, polystyrene, insulated. If the seal is unbroken and the blood is returned within 12 hours, that blood can still be used for another patient. And it's been a very interesting journey. We looked at our figures from 2005, and the average patient who lost or who needed more than 6 units of blood transfusion actually ended up with a total of 20 units because of their bleeding issues. In 2020, when we reviewed it, the average maximum blood transfusion, even in the most horrendous injuries, was 8 units average. So the number of blood units given to patients has come down by over half. That's a combination of better surgery, such as damage control, but actually also revolves around stopping the bleeding earlier. Use of saline is a big problem. This admittedly is 20 years old from the British London Times. Too much saline, major coagulopathy, bled to death. And then we can do other things. Hypothermia inhibits enzyme reaction. If you have a core temperature decrease of greater than 35 degrees, correctionally, temperature is less than 35, it carries a poor prognosis, and a temperature of less than 32, 100% mortality. What is the temperature of your environment? The crew in this plane, unfortunately, both lost their lives because they froze to death. And we put on protective clothes in the ED and the operating room, take the patient's clothes off, and then poison them with additional chemicals. This is one of the very first Boeing 707s. You'd be delighted to know that we're not poisoning quite so much, but the use of any starch products should be absolutely banned, because the problem with starches, all of them, is they actually chelate factor 8, they chelate von Willebrand factor, and they all end up with more blood needed. I wanted to cover the CRASH 2 study briefly. This is quoted at everybody, and to put out a warning on tranexamic acid. It is not a panacea. The data from CRASH 2 essentially was on 20,000 patients. 10,000 got TXA, 10,000 did not, and there was a significant improvement in mortality with TXA. But the study was flawed. Most of the centers were using it were not particularly well controlled. Both groups only received 3 units of blood. So look to yourself. If your patient needs only 3 units of blood, a 14% mortality, is that for real? Or 16% mortality? And no data could be obtained from CRASH 2 on what the actual cause of death was. What it has come down to is, if a patient is continuing to bleed and there is no blood product, so you can do goal-directed blood resuscitation, TXA has a good indication. But that is patients who are going to end up with massive bleeding, and you probably are going to take a while to get them to a major trauma environment. That's fine. But in 2021, there's a good reason why the United States and South Africa do not routinely give TXA to all except our rural long-distance patients. And actually, this is the reason. This is known as the Thrombo-Elastogram. It comes in a different form as a ROTEM, rotary thromboelastomorography, difficult to pronounce, but does the same thing. Essentially, and the newer ones are all cartridge-based. What you're looking at is a graphic representation of a clot. When you put tissue factor, which precipitates clotting, into some fresh blood from your patient, for a period of about 8 minutes, the clotting factors develop. The tissue factor stimulates factor 7A and others, and a clot starts developing. This is known as the reaction time. Then, once factor 13 is activated, it starts activating fibrinogen to become fibrin, and that activation time usually is about 2 minutes. That's the little black nose of that bullet-shaped thing. Then you end up with the formation of a clot, platelets forming on the fibrin, and the speed with which that clot forms is known as the alpha angle, and you can see that on the graph. The steeper the angle, the faster the clot is forming, until the clot has fully formed. And you can do that by measuring the amplitude, and normal amplitude is greater than 50. And then you want to see if that clot is stable. If it's not and starts dissolving, the lysis time, that's where your tranexamic acid comes in. So tranexamic acid stabilizes a clot. Tranexamic acid has no effect if you have no clot to stabilize. So rather than focusing on the tranexamic acid, most centers are focusing on getting the R time back to normal, getting the K time back to normal. So clotting factors for the R time, K time is fibrinogen, alpha angle is platelets, and then possibly TXA. Now, is this hard to remember? Not really. I understand that the Asia-Pacific region has not got the highest drinking problem in the world, but if we look at glasses, the normal clotting factor profile is actually a red wine glass. Initially, after you're injured, you end up hypercoagulable, a bit like brandy. And it's treated using heparin, actually. This is also what you will see in COVID patients. The other side of the coin is that you get patients with a much longer R time, which is clotting factors, treated with fresh frozen plasma, and cryoprecipitate or fibrinogen in order to improve the slope of your champagne glass. Of all of those, long-term coagulopathy from trauma is the test tube, And if you see that your clot is diminishing in size on the bottom right of your picture, this is the patient for tranexamic acid. So in 2021, tranexamic acid is the means of choice. So there, what you do: fresh frozen plasma, fibrinogen, sometimes supplemented with DDAVP, K-time with cryo, platelets, and TXA for everything else. Those are your baseline bloods. Note that your TEG, we would do a TEG around 5 to 10 minutes after admission if the patient is bleeding, because we rapidly will be able to follow goal-directed means of seeing how things are happening. Frankly, INR is not adequate, and D-dimer takes too long. Use emergency blood if necessary. Microaggregate filters slow the blood down. If you can get whole blood, wonderful. If you can't, use a 1:1:1 blood to fresh frozen plasma to platelet ratio. When do you stop? When the patient is not bleeding, when there's no further need for red cells, remembering you're trying to reduce the need for red cells, and when the lactate says you are carrying enough oxygen to the tissues. Blood transfusion is actually a last resort and probably an admission of failure. Your resuscitation must be goal-directed. In 2021, that is probably going to revolve around thrombo-elastography, which is goal-directed and dynamic, just as lactate is goal-directed and dynamic in oxygenation. I'd like to thank the organizers for this. I'd like to thank all of the initiative, and most of all, I'd like to thank you, the participants. Thank you very much.